You will find as many ways to perform a Toogle Recoil as there are chiropractors. The protocol that we describe here does not take into consideration any dogmatic opinion. It addresses first the comfort of the patient, the comfort of the doctor, while providing the highest safety to the patient. So we're going to limit the treatment here to the occiput atlas interspace. And that can be used on a very acute patient with great comfort. And how does it work? It's basically a vibration that will happen between the occiput and atlas, and that vibration mechanism unscrews the tight coaptation of this articulation. So the patient is sidelined, and we have our knee slightly bent. The headpiece has been raised up gently, and we have roughly a 15-degree head extension to relax the nuchal ligament. The doctor is facing the patient, and we can check the cervical drop if it works well, and we have set one perfect. So I'm going to take a pisiform contact on the lateral arch of the atlas, and I'm going to move the thorax of the patient. Basically, I'm going to move my thorax just over that patient to perform that motion. The height of the table will be at my arm length. What I want to do, I want to keep my shoulder square, and I want to have my elbow semi-extended like that. So as I deliver a drop, I will not use my shoulder, but basically as a safety precaution, I will just have a light, shallow drop by extension of my elbow. So I'm going to go just right above the patient, square my shoulder, take my contact, put a supported pisiform contact, lean gently, stabilize, and I want to make sure that the drop is kicked in. Beautiful. Good. And that's it. Very easy. So what is the mechanism of action? The mechanism of action is basically a vibration. And what it is, it has a head drop. The amplitude of our thrust is not going to go all the way down the end of that motion of the head. It's going to recoil before. And that will create a sinusoidal wave that usually breaks very well adhesions.
An open mass X-ray can be useful in determining which side of the atlas is posteriorly anterior and lateral. A universal principle of spinal manipulation to be remembered. A thrust is delivered first in the opposite direction of the postural mechanical osseous deviation, if any is evidenced or perceived, obviously. Now, to exemplify that, for a lumbar retrolisthesis as seen on the picture, L5 is being posterior to L4. Then the thrust should be preferably given posterior to anterior on L5 as here.
And we delivered a posterior anterior drop on the posterior segment.
So this statement results in two rules that can be applied to a Toogle recoil positioning. Rule number 1. The lateralized side of the atlas will be positioned up in relation to the headpiece. So if C1 is lateralized on the right side of the patient will be up on the headpiece. Rules number 2. The doctor should stand on the side of the anterior C1 atlas transverse. The anterior side of the atlas is up on the table. The doctor's thrust is a push. It is easier for the doctor to push away in a derotation of the atlas. Determining the postural lateralization of the atlas through an open mouth X-ray. The odontoid process, you sit right in the middle with the lateral mass of the atlas on the side. And we are looking at the width of the atlantodental interspace. So determining the postural lateralization of the atlas through an open mass X-ray and through that ADI, atlantodental interspace. So observe on the top, we can see the odontoid process here in blue, and we can see it also on the X-ray and then on the schematic version of the AP open mass X-ray. Now the lateral mass, the same thing. Depending on the head rotation, observe that the atlantodental interspace is reduced on one side, either right or left, depending on the head rotation. Let's take a look at the head rotation. If the head is being turned on the right side, like on this picture, then the atlas turns with the head, not C2, the atlas. The lateral mass of the atlas of C1 on the left here, this lateral mass, superposed with the odontoid to a certain degree. The X-ray open mass show a narrowed ADI on the left due to the superposition of those structures. So the left ADI is narrower on the schematic version of the X-ray, and on the X-ray, the left ADI will look narrower. Still, for the narrow ADI, the patient head will be placed right side down and narrowed ADI up, which if we look at the X-ray, you would not think this way, but it's how it should be. And the doctor being in front of the patient. So I repeat, right side down, narrowed ADI up, and the doctor in front of the patient.
In summary, the patient will be positioned sideline with partially bent knees. The cervical spine is in neutral position and in perfect alignment with the upper thoracic. The junction cervical occiput is brought in light extension for relaxation of the nuchal ligament. So how do you compare the mechanism behind the Toogle recoil to the one behind the arc of tension model? The Toogle recoil aims at inducing a vibration, and a vibration is stopped by the stiffness of the structure. Example, if the neck ligaments are maintained in flexion, they stiffen up and stop the propagation of the sinusoidal wave. So Toogle recoil works a bit in the opposite of the arc of tension. With Toogle recoil, no tension is better, as it keeps the sinusoidal wave at the maximum amplitude.